a sensory exam. There's 5 main modalities that I'll test. I'll test light touch in the areas that I normally test. Certainly for your case, if your case says, well, he has loss of pinprick in this area, then kind of map that out. I forgot to do that, actually, and I'm thinking out loud. Maybe I'll demonstrate for you guys how I would map it out in just a second. So I would test for light touch, kind of, say, in the shoulder area. So for a C5 area here, and then so the lateral lateral forearm would be C6, middle finger would be C7, kind of C8, kind of medial aspect of the wrist and forearm, and T1 kind of around the elbow. Okay, C5 through T1. And then for the lower extremity, I'll start low and work high. So S1 is kind of around the heel. L5 is on the dorsum of the foot. L4 is the medial aspect of the leg, and L3 would be right on top of the thigh. Okay? If your case has different levels, then go to that different level. If he has some type of, say, a T4 spinal cord level, we are talking about the spinal cord, I like, on the back of the patient kind of say, okay, that's normal, right? Yeah, that's normal. Tell me when it changes, and then kind of walk down the back. Okay, it changes right there. And then so you kind of get a feel for where on the trunk where that meets, and you have your landmarks, T10 umbilicus, T4 nipples, that type of thing. You kind of gauge things from there. You can also certainly compare side to side. And again, one thing that I didn't do across the hall, maybe you should go back, is to say, okay, folks will tell you, hey doc, my hand is numb. Okay, so you establish, say, okay, that's numb. Yeah, that's numb. Okay, so you can say, well, tell me when it starts to feel normal again. So I'll just walk and say, okay, right there, is where it changes, and so you can kind of mentally mark that. So again, kind of pertinent to your cases and for your demonstrator. Oh, there's where it turns normal for you. Okay? Does that kind of make sense? Okay. So the modalities that I test: light touch, temperature. Your tuning fork's a nice thing. This is truly cold. Okay. So in your various areas, light touch, temperature. Since I've got the tuning fork in my hand, need to be models of efficiency in the clinics there. So go ahead and test for vibration here. Feel that buzzing?
I do.
Okay, tell me when it goes away. And when it goes away, you don't have to hold it. You just kind of, it's gone. Okay? So if he doesn't feel it at the toe, I'd go up to the ankle, or I'd go up to the tibial plateau and kneecap, that type of a thing. Obviously, the more proximal I go, the greater the deficit would be. Okay? All right. And so since I'm down here, so light touch, temperature, vibration, and then proprioception, it's actually going to shift around 90 degrees over there. This is just so you guys can see what we're doing. Okay, so I'll grab the sides of the big toe and then kind of demonstrate to the patient, okay, I'm going to move it up, we're going to move it down. Okay, close your eyes. You tell me which direction. Up, down, down, down. Okay, so again, the order, I'm kind of making up the order from patient to patient. I know what I'm doing. He doesn't know what I'm doing, but I kind of get the degree over time of what's normal versus abnormal. Obviously, if I yanked it way down here, and he said, I don't know what you're doing, that's abnormal. Or, gee, doc, I don't feel anything. Okay, then I'm going to move the whole foot. That type of a thing. Okay? And then, if you guys have a safety pin at home, you guys can maybe bring that in. The best thing I can do for pinprick or painful touch is just to kind of snap the Q-tip in half, and it's a bit sharp, yeah?
Yep.
I mean, it's not terrible. But,
not bad.
But yeah, I like to use safety pins, and because that really gives me something really sharp, and you can kind of say, okay, this is different than that kind of thing. Okay? So, light touch, temperature, vibration, proprioception, and pinprick. Okay, those are the 5 sensory modalities since I'm still on sensation, but again, I don't do it in this order. I kind of do the patient sitting down, lying down, and standing up, so they're not exhausted by the end of the exam. Just for demonstration purposes, let me have you stand up, and we'll test. I understand Dr. Mears went over Romberg testing with you, and so Romberg testing. I still have a lot of fourth-year students who forget this, but basically with Romberg testing, I'm testing dorsal columns. I'm not testing the cerebellum. For us to stand upright, we need two systems. We've got three systems to help keep us upright: the vestibular system, the proprioceptive system, and our visual system. Okay? So in Romberg testing, I'm assuming that the vestibular system is intact. So you really can't test Romberg in someone who's dizzy, who may have an inner ear infection or something like that. That's not fair, okay? So to test Romberg, go ahead and put your heels and your toes all the way together, all right? So vestibular system's intact. Close your eyes. Now, all he's got to keep him upright is the proprioceptive system, because I'm assuming vestibular. He's doing fine, right? Okay, now if someone doesn't have an intact proprioceptive system, when they close their eyes, they've only got one system keeping them upright, so they can't do it. Now, in someone who's trying to feign something, they're going to kind of sway and rock around and things like that. But if you think about it, it's going to take more coordination and input from the posterior columns and the cerebellum to maintain your uprightness than really what happens in true disease, which is you fall like a tree. Okay? So let me have you close your eyes and just fall back to it. Okay? And that's exactly what happens. Is they just, so you got to kind of trust me. I'm a doctor type of thing for demonstration. Please don't have anybody get a coup entry to their occiput. Okay?